in-hospital outcome was uneventful with ejection fraction, actually normal ejection fraction. He had no excess bleeding during hospitalization, and the recommendation at discharge was clopidogrel for 3 months only, aspirin 100 milligram, and of course secondary prevention measures. So the key point for actually from this case, and I'm going to show you another case of non-ST elevation ACS, that these patients have normal coagulation system during the procedure if they are treated pre-procedurally by factor 8. Of course, radial access is always preferred because of reduced thrombotic bleeding complication. We have to use a minimal antithrombotic regimen in the setting of ST elevation MI, maybe heparin only or bivalirudin. We have to use bare metal stent instead of drug-eluting stents, and to use a short-term therapy with dual antiplatelet therapy. The second case actually is a relatively young patient, 51-year-old, again with hemophilia A, again with factor 8 levels of less than 1%. He has HIV, some risk factors including diabetes mellitus and hypertension, and this patient suffers from severe hemarthrosis and actually is on a wheelchair. This patient presented actually with effort angina for several months and admitted to cardiology department with non-ST elevation MI. He was pre-treated by aspirin and clopidogrel loading of 300 milligrams, and before performing coronary angiography, he received again a recombinant factor 8. Again, the radial access was used, and the patient received low-dose heparin before the procedure or before PCI of 60 units per kilo. No 2B3A, no other drugs. So this was his first procedure. You can see the lesion here. Looks like a thrombotic lesion in the proximal LAD involving 2 diagonal branches. The patient underwent direct stenting, and this is the final result. As you can see here, direct stenting and another projection. You can see good, nice recanalization of this artery. This was not the end of the story. Actually, the in-hospital course was uneventful. He received dual antiplatelet therapy for 3 months, and at follow-up, he had severe bleeding while on dual antiplatelet therapy, requiring increased doses of factor 8 during a follow-up. After 6 months, he was seen again at the clinic, and he reported to have mild effort angina. We performed spectalium showing only mild anterior wall ischemia, so of course we recommended conservative therapy. But 1 year later, he was readmitted again with non-ST elevation MI and referred again using the same protocol to a repeated coronary intervention. And then we were faced with a different problem, which is severe in-stent restenosis of the stent in the LAD, of actually the distal part of the stent in the LAD. And I'll show you it here. As you can see it here, severe stenosis in the distal part of the stent. And then of course we faced another problem. What should be the options here? Do we need to use drug-eluting stent in this case, or maybe just balloon angioplasty? And we thought that this is a very good indication for drug-eluting balloon, although back then, I think it was about a year ago, it was not available still in our hospital. So we treated this patient with actually a cutting balloon, as you can see here, and received adequate result. And actually since then, which is almost 1 year, this is result after. We try to be very minimal here, trying to avoid distal dissection, so we just inflated the cutted balloon inside the stent, trying to avoid the placement of additional stents. As you can see here, this is the final result here. The stent is still not regular, but the patient is doing fine. So the key points for this patient: first, that bare metal stents are always preferred, but in-stent restenosis is a major problem, and the treatment options here are repeated balloon angioplasty, a drug-eluting balloon. We think this is a technology that will be suitable for this kind of situation. DES, of course, will require at least 12 months of the dual antiplatelet therapy, which is problematic in this patient. And again, bypass surgery is also, the handling of bypass surgery in this patient is very problematic. So my general conclusion regarding these two patients, and actually we have experience with more, is that hemophilia A Fortunately, hemophilia A and other severe coagulation disorders are relatively rare. The improvement in survival due to the effective replacement therapy allowing this patient to develop coronary artery disease, including thrombotic complication, although they have bleeding disorder. The antithrombotic and procedural management are complex and require a delicate balance between the risk of bleeding, stent thrombosis, and restenosis. Thank you very much.